Welcome to another EduMed video, and in this video we'll be talking about the most recent ICNARC report on COVID patients that have been admitted to intensive care. This is a really interesting report because there's a few additional things that they've added in and analyses that will be useful, especially in the debate about whether patients who are of black and ethnic minority origin are at higher risk of developing severe COVID infections. And thinking a little bit about socioeconomic background, which has certainly been purported as one of the potential reasons for the slightly skewed data that we were seeing. Just in terms of the general demographics and status that we've got in the intensive care at the moment, there's a couple of things to highlight. The number of units is starting to go up as they're creating more units around the country to help with capacity when there might be a second surge. So we're starting to see many more units starting to become available. What I do take quite a lot of heart at is the fact that the number of units with 0 patients is slightly going down, but there are still some units with no patients, so we've still got some flexibility in our services around the country. But overall, the numbers of patients are slowly going up. We're getting a lot more data now. We're starting to get almost 8,700 critical care admissions over the course of the last month or so. And of those, we've got 6,720 where we've got full data. And I think that's really useful because the trends that we're starting to see now are probably more representative of the actual true data. Because before, the numbers were so small that it was difficult really to tease out what was noise and what was actual true signal. We are still seeing about 50% of people who are dying compared to those that are being discharged alive, and there's still a huge number of patients in critical care, although it looks like it's reached a bit of a steady state, which is again quite heartening. I think this is a really interesting graph. What it shows is the number of new patients for every day. And what you can see here is that we were in that rapid rise up until round about the start of April. And now, as the social distancing initiatives are starting to take effect, you're seeing that the numbers of patients are starting to drop down and the number of admissions are starting to come down. The thing to look at would be the notifications, where you can see that it was plateauing for a while and now it's starting to drop. Hopefully, this might indicate that we're coming to the end of this first phase of the disease. This is by no means to say that this can't then rise up again, especially as social distancing rules start to be relaxed. However, at least the capacity of the intensive care seems to have been enough for this initial surge, which again, I think is very encouraging. This is also reflected anecdotally, and certainly we're seeing in a lot of units that the numbers of new patients being admitted and number of patients being intubated on the wards is dropping quite significantly from where we were 2 or 3 weeks ago. In terms of the summary of the data, again, it seems fairly similar to that which we had before. So, around the average age of patients who are being admitted to intensive care is around 60. That's not to say it's people at age 60 who are getting critically unwell, but that's the average age of the patients who are being admitted. So we've got to bear in mind that there are some patients who are older or those patients who, with their frailty index, may be people who are being excluded from intensive care. But of the ones that we're seeing, around 60 is about the age. Now, interestingly, this signal of it being predominantly males who are getting severe COVID-19 infection, resulting in them coming to intensive care, has persisted, and it's still around 70% of patients. So there's a huge number, more than 2/3 are male. You compare that to the seasonal viral infections like the flu or any of the non-COVID infections, where it's almost an equal distribution between the two. And that signal we saw very early on, not just in the UK, but also in China and in Italy as well. Thankfully, of the women who are getting severe COVID infections, the majority of them aren't pregnant, and it doesn't seem to have a predilection towards women who are pregnant. Now, I put the same proviso as I have for the last few weeks. We have to bear in mind that the pregnant cohort are probably much better at self-isolating and are probably much more protected, and so that might be a slight confounder. I certainly wouldn't rest on the laurels of saying that this would indicate that women who are pregnant are protected from COVID. That's certainly not what the data is saying. What's been really interesting over the last few weeks has been this signal of higher propensity of patients from a black and ethnic minority background having a predilection towards developing severe COVID, i.e. being admitted to intensive care. And certainly if you were to just compare like for like viral pneumonias and COVID pneumonias, you can see that Asians and blacks are almost 3 or 4 times more likely to have COVID infections than they are with viral pneumonias. And we mentioned a number of different potential reasons for that. One of them is the fact that it's still a fairly London-centric data set. The majority of infections that we've seen with COVID that have resulted in intensive care have been in London. And proportionately, there's more black and ethnic minority people in London who may have then gone on to get the disease. Also, we talked about the confounder of black and ethnic minority groups tending to be of lower socioeconomic status and therefore having more deprivation. And this is where it's really exciting, because for the first time the ICNARC data has actually reported an index of multiple deprivation and looked at the numbers of patients with confirmed COVID who have come to intensive care with levels of deprivation going from the least deprived to the most deprived at number 5. This is really interesting because if you look at it on the face of it, just looking at this data here, you can see that the patients who are least deprived have the lowest percentage of people with COVID-19, 14.8, and those that are more deprived, so indexes of 4 and 5, are much more represented in the intensive care population. Now, you might think that that's fairly obvious because patients who tend to be in less deprived areas tend to be more healthy, tend to look after themselves, eat better, maybe more compliant with their medications or seeking medical help at an earlier stage to diagnose those conditions which may be left undiagnosed otherwise. But if you compare it to the viral pneumonias between 2017 and 2019, i.e. before COVID-19 came along, you can see actually that the numbers are relatively similar. Now, we don't have confidence intervals, so I can't tell you whether they overlap, but just on the face of it, 14.8% as opposed to 15.3%, 24.7% compared to 26.1%. They're all fairly close, and the numbers themselves aren't that big, 6,700 versus 5,782. So, although it seems like the more deprived people are, the more they tend towards having severe infection, i.e. coming to critical care, the deprivation indexes seem fairly similar between the two groups. But then, if you take the same data points and have a look at the representation of those with black and ethnic minorities, for exactly the same data groups, you can see here that 15.4% of Asians were in critical care compared to only 5.8 in the non-COVID infections. So even taking into account multiple deprivation indexes, there does seem to be a predilection towards the black and ethnic minority groups. Having said that, the general trend towards those who are more deprived having severe infections still holds. A really interesting thing that we are seeing a lot more clearly now is the fact that if you look at body mass index, patients with non-COVID viral infections, we often did see that they seemed to affect disproportionately almost the patients with a lower BMI more severely. However, in COVID, it seems to follow more the population, with most patients being in the BMI range of 25 to 30, and that being the highest peak, and then everything sort of falling off to the sides on either side. And possibly even the fact that having a lower BMI might protect these patients from having severe COVID infections. Now, in terms of the multiple deprivation index, it's a fairly well used indice, and it's been published in a number of different places. It looks at a number of different domains and weights them accordingly. Income is the thing that has the biggest impact, with 22.5% of it being apportioned to it. And then other things such as employment, education, health, crime, housing services and barriers to it, and living environment being the other things. There's a lot more information about how this is calculated in the description box below, but this is essentially what they are looking at when putting people into the 5 quintiles of how deprived they are. This figure is just really to show the fact that it's still fairly London-centric in terms of the data that we have. However, rather concerningly, we are now starting to see a gradual increase in the other areas, especially in the north and mid parts of England. We don't have the data for Scotland here in the ICNARC data, but certainly in places like Wales, it's still relatively rare to find patients coming to intensive care with COVID infections, and that might be partly related to the greater population distribution, and so they're more sparsely distributed, meaning that patient-to-patient transfer of the disease is a little less likely. As time goes on, as I keep saying, I expect all of these to go forward, and I suspect that once social distancing starts to be relaxed, again, each of these graphs will start moving outwards, and we'll get more data that's more representative of the whole country. The graph itself, looking at age and sex distribution of patients with confirmed COVID infection in critical care, hasn't really changed much over the 3 or 4 previous reports. We're still seeing a massive difference in the number of men compared to women at each age group, with the men being overrepresented in each age group, tending to suggest that there is a propensity of this disease to cause severe illness in men compared to women. And actually, this is then compared to men and women with non-COVID viral infections, which are the lines. And you can see that the women's one and the men's one seem to follow a fairly uniform route for both of them, with maybe a slightly higher propensity for severe illness in non-COVID viral infections in men, but certainly not the same sort of stark difference that we're seeing with the COVID infections. Now, although the ICNARC data tries to show this, I think actually this belittles some of the big increase in risk that is being seen in the black and ethnic minority groups with COVID infection. If we have a look at this, the solid bars are the patients with COVID infections, and the orange line is what the representation would be of the local population. And here you can see that there is a slight difference in the numbers of with slightly overrepresented Asian, Black and other group. But I think that belittles slightly the size of that difference, partly because the numbers are so small. So there definitely does seem to be this signal towards Black and ethnic minority groups being more overrepresented in critical care COVID groups. Now, whether socioeconomics has some part to play in it, it's difficult to say, although as we were mentioning in the previous tables and graphs, maybe it's not all to do with socioeconomics, and certainly there are some papers starting to suggest that maybe some genetic predispositions to severe COVID are present, and some suggestions of things such as the ACE receptor of wild phenotypes and genotypes, meaning that these patients are at higher risk of developing severe complications, might be in part an explanation. But certainly we do know that an increase in deprivation score causes patients to have more severe disease, possibly due to them having underdiagnosed with other comorbidities, or maybe just a poorer level of general health due to them being more deprived. And I think this graph quite clearly shows that if you look at the representation, so on the side is the percentage of patients who are in intensive care, you can see that the least deprived people are the least represented in intensive care, and as they become more deprived, you're getting more and more people coming in to intensive care. And this is compared to the average here of the general population. Interestingly, however, if you look at it compared to the non-COVIDs, you can see that the general trend is still there as well. However, you can see there's this sudden jump up at 4 and 5. Now again, this is a small number of patients, and they don't show the confidence intervals for these graphs, and so it's difficult really to take too much out of it. However, the general trend that the more deprived you are, the more at risk you are, certainly seems to hold. In terms of age and sex matched for BMI, again, that trend that we were seeing with the non-COVID viral infections having a predilection towards those with a low BMI, and those with COVID seeming to follow the general population distribution fairly accurately, tends to indicate that it seems to affect all BMIs equally in this. Now again, there's a number of confounders with this, especially with regards to comorbidities. We know that things like hypertension and diabetes tend to increase the risk of patients having severe illness. And also there is a bit of a selection bias here with things like the clinical frailty index giving an indication as to whether patients should be considered for intensive care, taking into account some of these comorbidities, meaning that they may be precluded from actually entering intensive care and therefore being in the ICNARC audit data itself. The main thing that I want to point out with this table is that it's pretty similar to last week and the week before. But again, just how striking it is that these patients that we're admitting into intensive care, over 90% of them were really fit and healthy, independent, able to live without any assistance with daily activities. Compare that to 70% in the viral pneumonias between 2017 and 2019. So certainly these patients are in much better premorbid condition than what we should be expecting with other viral pneumonias, indicating again that the higher mortality that we're seeing is probably a true reflection of the disease severity of this particular virus. In terms of comorbidities, just in general much less than what we see in the viral pneumonia group that we're using as a control. And partly that's related to us just probably being a little bit more stringent in who we're allowing into intensive care and having a little bit better thought as to who would be appropriate for level 2 and level 3 care. In terms of the prior length of stay in hospital, it's still quite short before they're being brought into intensive care. 2.5 days roughly is the mean, with the median being 1 day. So we're making very quick decisions to bring these patients to intensive care. And the mean you can see is almost a day greater in the patients with viral pneumonias. Now, part of that might be the fact that we're using quite a lot of high-flow nasal oxygen on the wards with non-COVID patients back in between 2017 and 2019. And certainly when this pandemic started, we were of the thinking that maybe we should avoid using high-flow nasal oxygen for the risk of aerosolization of the virus and potentially exposing other healthcare workers and patients to a high viral load. That in and of itself is something that may well change over the next few weeks and months. I think this is still probably one of the most sobering tables, and it hasn't really changed over the last 3 weeks. What you can see here is that almost 50% of patients who are coming to intensive care are dying. You compare that to only 20% with the non-viral pneumonias, so the mortality is almost double that of the non-COVID viral pneumonias. So this being different to the seasonal flu and things really is quite stark. It is twice as deadly for those patients who are making it to intensive care. What's also quite stark is how long these patients are staying in intensive care. Even though the median length of time that they're staying for survivors is 6 days, and actually for non-survivors, for the ones who are deteriorating to death, it's still 7 days, so it's a long period of time. And you can see here the range is between a few days and 2 weeks. And this is fairly similar to that of the viral pneumonias that are non-COVID. There's a lot of these patients who are requiring advanced ventilatory support. But what I really want to highlight here is how many of them are requiring renal support. When this first was being reported in China and Italy and even Spain, it was being billed as a single organ failure condition, with it mainly having respiratory consequences. But you can see here that 1 in 5 to almost a quarter of patients requiring renal support. And that's quite significant, both in terms of the kit that is being required, the consumables that are required, and also the skill mix of the nurses that are going to be required. There's a lot of big hospitals that are being created as temporary intensive cares, which will not have the ability to filter patients. And I think that we do need to bear in mind the fact that almost a quarter of patients are going to need this advanced level of organ support. It's also interesting to see how long they're requiring the organ support, and you can see here that advanced ventilatory support, so this is intubation and ventilation, it's about 8 days. And interestingly, for renal support, it's 5 days. This does compare pretty similarly to that of the non-COVID viral pneumonias. But again, these patients are going to be around for a long time in intensive care. And so if you remember back to one of the first graphs I showed with the number of patients that are being admitted into intensive care dropping down, in terms of the number of patients actually in intensive care, it's still plateauing and only just starting to drop down now, because a lot of these patients are going to be hanging around for a while, up to a week to 2 weeks in intensive care. So there'll always be that slight lag. A lot of the tables that I showed talked about advanced and basic levels of organ support. This just defines some of those. I won't go through all of these, but I'll just leave it up there. If you want to have a look, just pause the video at this point. I keep emphasizing this point based on this table because I think it's really important, because a lot of young people were thinking that this is a disease of the elderly and they wouldn't be affected. But if you have a look at this here, 21.6% of patients under the age of 40 died in critical care. That's 1 in 5 died in critical care. So although this does predominantly seem to be lethal in the elderly patients, with almost 70% of those over 80 coming to intensive care dying, and similar sort of numbers in the 70 to 79 group, and more than half of those over the age of 60 dying, actually, it still kills a lot of young people. So this is not something trivial, and it's not something that young people are immune from. As we say, although the number of patients who are male in intensive care is higher than females, actually if you look at everyone who enters into intensive care, it seems fairly equal. About 50% of patients are dying, 50% of patients are surviving between the men and the women. So once you're in intensive care, that difference in sex seems to peter out and not be as significant an issue. Really interestingly, if you look at the numbers of patients who are dying, they all seem to be about 50% between the different ethnicities. But you can see here that black patients with non-COVID viral infections seemed not to die as much as, say, for example, white patients. Interestingly here, all of them in the COVID groups are around half, so about 50% are dying. With Asians, maybe there's a signal towards an even higher mortality. Now, this is not adjusted for comorbidities, and there is a suggestion that those in the Asian subpopulations have a higher rate of hypertension and diabetes, which may be increasing the mortality of these patients. What's also really interesting is that the mortality between the different quintiles for deprivation, so the least deprived to the most deprived, are all fairly similar between those that are dying in intensive care and those that are surviving. It's about 50%. This is significantly higher than the non-COVID viral infections, but that mortality being double reflects just the mortality of COVID compared to non-COVID viral infections. It's also quite interesting that although if you look at people who required assistance with activities of daily living, 60% of those who are required assistance with activities of daily living died, compared to 40% who survived. So having comorbidities, being frail, does seem to confer a risk towards death in intensive care. And so that does tend to indicate that using things like the clinical frailty score may be useful in helping to guide patients and their families as to the appropriateness of higher level care. The signal that we were seeing right from the start, really, of those who require early mechanical ventilation, so intubation and ventilation within the first 24 hours, having a much higher mortality, still stands. If you remember, when it first reported, the first 2 or 3 reported mortalities of about 70%, you're seeing now that that's starting to move up. And as we're getting better at managing these patients, all the quality of the patients themselves is getting better, so those that are less susceptible to the disease severity, we're seeing that these patients are surviving. So we're now roughly at about 60% of patients dying and 40% of them surviving. So still not great. But compare that to almost 70% surviving when they aren't intubated or ventilated in the first 24 hours. So again, there is that stark difference between those that are being intubated in the first 24 hours having a higher mortality than those that we can keep off the ventilator. Now, one might say that that's quite intuitive because you're intubating the patients who are much more sick, but also there is an increasing question as to whether intubation and ventilation is injurious to lung and therefore worsening and exacerbating these patients' mortalities. We won't know until we do more studies looking at things like non-invasive ventilation and looking at things like high-flow nasal oxygen as they become more prevalent in the intensive care management of patients. I think it's really interesting just to have a look to see what proportion of patients die depending upon the organ support they have. Now, in terms of the data for intubated patients, we know that about 65% of patients are dying if they're intubated at any point in their intensive care stay. But what I think is really interesting is looking at the renal support. Again, it was billed that this was going to be a single organ failure disease, but we're seeing almost a fifth to a quarter of patients coming to intensive care requiring renal support. And almost 80% of these patients are dying if they're being put on renal support. Compare this to less than 50% in the non-COVID viral pneumonias. So it's a very bad prognostic indicator, much worse than with non-COVID viral pneumonias, if they are put on renal support. I think that's interesting to note, and something that's worth discussing with both the family and with the patient as well if they're awake, that this is a bad indicator and to prepare patients for the worst with only a 20% chance of survival if they get filtered. If we look at length of stay for patients in critical care, for those who are intubated and ventilated, you can see that survivors are spending roughly 2 weeks in intensive care. Compare that to those who are only receiving basic respiratory support, where it's only 3 days. So once they're intubated and ventilated, these patients are in for a while. And even in those patients who deteriorate and die, it's still taking 7 days as a median, but this can be as much as 2 weeks, you can see here from the interquartile range. So again, once these patients are in intensive care, we're talking about a week to 2 weeks before they either die or get out of intensive care, meaning that even if we flatten the curve, it will take a while before the numbers of patients in intensive care start to drop. This reflects pretty much the same thing, but in terms of renal support as opposed to ventilatory support. And again, I think it's really interesting to say that for those patients who are surviving with renal replacement therapy, they're spending 2 to almost 3 weeks, so almost a month in intensive care, really, when you're looking at it, for these patients who are surviving. So again, if they're put on renal replacement therapy, not only are they at high risk of dying, but also if they were to survive, they're that sort of roughly 30% who survive, we're talking about 3, maybe even 4 weeks in intensive care, with the concurrent risks of nosocomial infections, significant muscle wasting, deconditioning and delirium that offers as well. So having open and honest conversations early with these patients and their families is useful based on this data. So I think this is a really interesting ICNARC audit, and I think this particular report is starting now to look at some of the causative signals for why we're seeing certain propensity of disease in, say, for example, the black and ethnic minority groups, and also in patients who are older, BMI distributions, and so on. I want to keep highlighting the fact that although this is being billed as a disease for the elderly, there is a 1 in 5 risk of death if a young person below the age of 40 is admitted to intensive care. These patients are taking about 2 to 3 weeks to get out of intensive care, so even if we flatten the curve, stop the admission of new patients to intensive care, the ones that are here are going to be there for a while. Intubation really does confer a bad outcome, and we're starting to see more studies looking at the use of non-invasive mechanical ventilation with spontaneously breathing patients. Honestly, I don't know what of this is a confounder in terms of more sick patients tend to get intubated. However, I think it is useful, and certainly the ARDSNet papers and other papers have suggested that erroneous or lung injurious ventilation will cause lung damage that does increase mortality. So it's not surprising that once patients are intubated, their mortality would increase, even if we account for severity of disease. In terms of ethnicity, socioeconomics is an interesting thing. What this paper suggests is the indication that the worse the socioeconomic status, the more likely they are to come to intensive care. However, interestingly, the mortality seems to be fairly evenly distributed between the different indexes of deprivation. Also, we're seeing that it seems not to be the total answer with socioeconomic status and ethnic minorities, and that there might be an inherent, possibly genetic, propensity to severe COVID infection in patients of black and ethnic minority origin. And finally, the signal of renal replacement therapy being needed in a fifth to almost a quarter of patients is concerning, and certainly something to bear in mind, especially given the much higher mortality in patients who do go on to renal replacement therapy with COVID infection. So I hope that's useful, and I think as we're getting more and more ICNARC data, we're going to get a much better idea of what this disease is. There's a lot of work that needs to be done, and I'm really interested to see the first of the data analysis papers where they'll do multivariate analyses and also start adding in the confidence intervals for some of this data. And there will, in probably the next maybe month or so, be a few publications based on the ICNARC data looking at causes of the disease in terms of why it's affecting certain subgroups in a certain way with the levels of organ support they're requiring and the severity of illness that they have. Also, the UK government has commissioned a fantastic group of people to look at why people of black and ethnic minority origin are at slightly higher risk of developing severe COVID infection. And I think that will be very interesting. It'll highlight some interesting points, not just about the disease, but probably also about our health and social care of these patients, and also maybe give us an insight into more of the pathophysiology of this disease itself. As always, if you've liked this video, please press the like button, hit the subscribe button and hit the bell notification button, and you'll be updated of all the new videos that are produced, and we'll be trying to produce new videos at the very least every week. Thank you very much.